So I'm going to, can you guys see my slides on the screen?
Yes.
Yes, cool. Right, and I'm recording. So I'll get underway. And this is the second training course that you've had from Meaningful Measures, and this is for you guys, you poor unfortunate people that want to get in there and look at the MYCaW data itself once you've used the tool within the systems. So you've got a pot of data. This is about using and understanding the MYCaW data itself. That, I hope, is what you're expecting. That's the course I'm going to give. On the screen it says Marie Polly on the name of the slides, but I'm Helen Sears. I work with Marie. Marie put these slides together, that's why her name's there. So the course of today, can you see this next slide okay?
Yep.
Yep. What we're going to have is how we use the MYCaW tool in terms of the qualitative data and the data you get from that, and the written data, as it were. I'm going to show you how we analyze that, and then I'll show you how we do the quantitative analysis, so you can have a think about that. And also I'll show you how we do the analysis of the open questions at the end. And ask me questions at the end, but ask me during. So this is your space to come together with me and reflect on the potential data, the data you already have within the JOY system, and work with me to look at how you can do the analysis. It may be that you designate specific colleagues or specific people within your team to do this analysis. So other people here may just want to have a concept of it, and it may be that you pick and have a plan for having certain people to do this work, because essentially it is a bit of sit down, think about it, do the data analysis work. It isn't something that everyone can chip away at. So it's what I'm going to explain is how the analysis is done, what you can do with the data, what the data can look like. Okay, so I hope that makes sense for today. Is everyone sort of happy with this?
Yes.
Yeah, but do talk to me, use this as a space to think about it, and get in there with questions. Okay, so you guys have got MYCaW within your systems, and I know from the sort of implementation meetings we've been having that it is up and running, it is on JOY. There's more projects coming on stream. I know it's sort of a complex geography and levels of the project. As I understand it, though, and do correct me if I'm wrong, because we have so many different users of MYCaW all around the world, actually, that your project is principally looking at high intensity users, people who are sort of in the system, and you're trying to listen to their needs so that they aren't being misunderstood, and people who are giving support to them can give more appropriate care that enables better use of health systems. And within that, we've got this nice tool, which is actually the listening ear to people that are maybe in those circumstances that are, you know, high intensity users, and you want to know, you know, what they need help with and why they're sort of in that situation. I hope that I'm making sense. Is that the sort of core principle of why you've chosen MYCaW? Someone tell me I'm wrong here.
You're right, Helen.
Good. And you're using it. There's projects that you've got within hospital settings, within secondary care, but it's sort of primary care predominantly. I think that the data is being collected in.
Yes.
Yep. Cool.
With a view eventually. Yes. I mean, yes. Yeah. I think, yeah. I'll go with that, Helen.
Yeah. I know it's complex. And then there's other projects coming on stream which sort of have parallel links, but the sort of central tenet of the reason why you've gone in there and you've got this outcome measure is that you want to just ask people what matters to them and understand that profile and really understand the population's needs, and see if the support you're providing does enable people to have a better outcome. Just to say, I can't see if anyone's putting their hand up because my slides are sharing my whole screen. So if you'd want to make a comment or a point, please do just speak up or get someone to interrupt me if you can only use the chat. So yeah, I hope that sort of makes sense in terms of the tool. Now, so you've got this really cool data set, and just to say, we have got a podcast coming out, I think this week, of the project that we've done in Cornwall with it's sort of a community exercise using MYCaW. It's like social prescribing, but it's not. It's community workers using it, people going to complex families, knocking on doors and working with families for long periods of time. And we've got a podcast about the MYCaW data and the report that we produced for those guys. So I will send that your way because it'll bring it to life more. And I think you can see it working in practice. And those guys are very happy with the MYCaW profiles and data that they've had for their project down in Cornwall. So firstly, I'm going to talk about the qualitative concerns, those written things that people put on the MYCaW tool. What can you do with that, with the data? So you can look just individually at Mrs. Smith, and her MYCaW concerns, and you can actually work with her and use the tool to reflect with Mrs. Smith in terms of, when we first met with you, this is what the situation was, and wow, look how far you've come, and how are things now down the line? Because I realise you'll be having a flow of service, point of discharge, and maybe even follow up to see how people are. So you can work like that with people with the data. But what we really want to know, and what we're doing on this training course today, is to look in terms of, across your projects, across your areas of work, what the sort of bigger patterns are in the concerns, what the global data patterns are. And you can use MYCaW to look at, are your services actually addressing the issues that people write down in the first place? Are there things that people are saying they need help with that your provision of support is just not even able to meet? So you can map that. Do you have the right proportion within your budget for your projects to meet these concerns? You can sort of use the data that you collect to make arguments to say, do you know that 12% of people presenting to us need help with whatever? Please make senior people aware of those issues that the users are facing. And if you have these gaps in your service provision to provide support, do you then need to then shift and collaborate with other organisations, make cases to do different things? So that's what the data can really powerfully do, and it can really show where priorities and needs are. And we showed this when we collected data over, COVID. We saw the sort of impact of COVID, and we had to create new ways of understanding COVID-related concerns at the time. And there's cost of living related concerns as well. So things will change with time, and the MYCaW tool is very responsive to what's actually going on with people. And obviously you have different services within this sort of global license bundle that you have with us. Are there differences in concerns with the people in different types of access to projects? I realise I can't hold in my head all the different complexities of your different service setups, and that's for maybe you to then talk to me or think about what I'm saying here today to stimulate that sort of conversation. So it's about being inquisitive and exploring. But MYCaW, even though it's a simple sort of what are your concerns, what are your problems, it's a very powerful tool to get all of this information because you are listening to people. So the way we do it at Meaningful Measures, and the way we can provide you the information on this, and someone in your team, maybe someone in the business intelligence side, can go away and sit and do this work. The concerns you'll get is all of the qualitative written bits in that data and those questions. So you'll get essentially 2 columns of data which is what people's concern 1 and concern 2 are. You can do a qualitative analysis on that. You can add all of the concern 1 and concern 2 into one big column and do content analysis on this data set. And this is something that you can be assured of from our perspective, that we've got guidance notes and essentially a lookup table, a very detailed lookup table, which is a framework based on thousands of other people's concerns and worries that they've told us, and we have coded and we have worked out these patterns. And you can plug this framework into your data set. It does require someone to sit and code it at the moment. We don't have an AI solution. Give us a bit more time. We will probably be able to derive machine language learning in due course, but not for the next couple of years, I'm afraid, because we are only a little company. But it isn't rocket science to sit there, use our framework, have the column of the qualitative data and ascribe it a code for each response. And the more you do, the quicker you get. I can do 1,000 codes a day, and the way we do it is in Excel, and you can use our framework and it allows you to create frequencies, overall frequencies for those concerns existing in your population. And you can plot those as pie charts very effectively and profile the issues people are facing. So for your project, we suggest you use and refer to our personalized care coding framework. We derived this in 2022. It's based at the time on nearly 3,000 concerns, but we have many, many more concerns on our books now, and we are constantly looking and refining these coding frameworks. The way to think about it is we have split it into people having 5 main themes for the concerns. So you can code it globally into 5 main themes. Those themes are mental and emotional concerns, physical concerns, information and service provision concerns, concerns about well-being, and practical concerns. So these are the global themes. Within those, we do have individual categories for each of these themes. And each one of those categories has a really good, clear definition in our coding framework, which allows people to use that to say, so this is a concern about bereavement or whatever. And we do find that the work that we have just done with the Cornwall chaps has really sort of enlarged the practical concerns theme about jobs, work, money. That's sort of very interesting stuff. So we think that would be very relevant to you guys. So that's the framework. We do have other frameworks of meaningful measures. So we suggest that the personalized care one is relevant to you guys. We've got one for cancer, we've got one for carers, we've got one in the frailty context, we've got menstrual health one, and we've also got a workplace well-being one, which may be useful for other strands of this work that are related to work, but I'll leave that one for another conversation.
Helen, can I just ask a question?
Yeah, go for it.
Just thinking about the different frameworks.
Yep.
So for example, if you have carers in a cohort,
yep,
can you use the framework you just showed with
the
could you use both of those frameworks, or
ideally one?
Right.
And ideally you would have, because if you wanted to look at the specific needs of carers, that is I would say you don't want to be double coding and sort of representing in reports two sort of bits of data for one person. I think that the way we like to present the carers data is it's a separate cohort, because they do have different concerns. And when you've used it in Joy, you will be able to segment your data just to pull off the people that say they're carers in Joy. And the carers concerns are interesting in that framework is split into people that have their concerns about themselves being a carer, and then concerns about the person they're caring for. So it's quite a different coding framework.
Yeah, because I'm just thinking, so in Cambridge City 4, we're looking at, doing the high intensity user
Yeah.
project, but within that,
Yeah.
within that cohort, some of them are carers. So would you suggest that we use the carers framework for carers and or not?
I
Sorry.
would, yes.
Right, okay.
And if we haven't, I think we would have sent you the carers framework in the initial license package, but I can make a note to send you it again.
Thank you.
I'll send that on to you.
And I think Beth had a question in the chat.
Oh yes, go for it. Sorry, I can't see the chat. I'm really sorry.
I can monitor that for you.
Thank you so much. Beth, what was the question? Anyone tell me?
Sorry, where's it gone? Can anyone else see the chat?
Oh dear.
Hold on. Oh, she's just said, where does she find the framework?
Okay.
Knowing the role.
Okay.
Yeah.
Well, I can send both the personalised care and the carers one again after this to Kelly. And if you don't mind, Kelly, you could disseminate.
Yes, I can. I can do that. Yeah.
Okay. Right. So it does take someone sitting there with the job of doing the coding, and I do say someone, actually I mean potentially two people, in that the way we do it at Meaningful Measures is we have one person do the main set of coding, and then we have a colleague come in and do a random 10% code blind of the same data, and then we compare that data coding to make sure that we're in agreement, because it could be that you're having a bit of a funny day if you do all that coding, and you could get it all wonky. If you find that that random 10% is bringing up completely different results for both of you, we would suggest you the second person does the whole coding set and everything's resolved. But we tend to find that the check does work, and the guidelines in the coding framework are clear. It does work. It is quite obvious. There are some instances when people write concerns that you can't code. They might write something like, I'm really worried about the war in Ukraine, or something like that, like esoteric things that you can't help them with in your service. And it is okay to code them as miscellaneous and not possible to code. There are sometimes instances where people write two concerns down. In that instance, the guidelines from us, it does say this in the guidelines that we give the written instructions, but code the first thing that's written in the concern. Code the main subject, which is the first thing that people write in that string of text. So, for example, I'm frightened about falling down the stairs. So that would be fear. That's how you code that. So once you've done the coding in Excel, you could you get that sort of column of the codes. So it'd be theme 1, category F. So you get a 1F, whatever it is. You get a string of codes. You can, in Excel, perform a count if function and work out the frequency of those occurrences, or you can put those concern codes into a statistical software package and work out the frequencies, and that package will do that automatically. We have discovered a really cool free open source stats package called Jamovi, Jamovi, and I recommend that you look at that for doing the frequency counts, because it will save you a lot of time, and it's free, and it's like SPSS, and it's actually, I think it's better. It's a little tip for you there. So if you then get those codes and you've worked out the frequencies, you can work out the proportions of people providing those responses. And so you can work out the broad themes. This is what this slide is showing. This is dummy data, the percentage of themes in categories in the themes. And you can present it as a pie chart. And as you write it up in a report, you can say what's in those different themes. and it just gives you a nice painting of the issues that cohort is facing. So the main issue, the highest frequency issue in this example, is psychological and emotional concerns. And you can say what sort they were. You can split this high-level data by demographics, by age, by gender, things like that. So you can see different profiles of your service users and really understand maybe men and women are different. They're expressing different things. Find what they are and do some splits on the data. Within those themes, you can look at within the themes the actual labels of categories of concerns. So, within the psychological and emotional one, you could look at the different issues. This is an example of data that we collected from our frailty work. So we took the different things, but this is sort of looking at the top theme that we found for these guys in the frailty project is that mostly they were physical issues that people were facing, and you would expect that because they were frail people. So you can see that the grey chart at the top is saying the most frequent theme was physical. So if we then split the physical down into different types of category, what were people saying? So that within that category, mobility was the top thing being said. I'm really worried about getting around, about getting physically moving around my space. That was the main thing in that frailty project. And then there were other physical problems, conditions. Then it was pains and aches, then falls, etc. We always suggest you plot the data, the frequencies of these individual concerns within the themes in terms of the highest first. So it makes the person reading the information be able to see the sort of the top main themes coming out. And we suggest you do it as percentages. And then you can have those graphs in the reports. They look quite nice. And then we also suggest you do a sort of, a bit of writing about the findings, and you take some of the quotes from the MYCaW to give illustrations of the different concerns that you're writing about. So it brings it to life. So here's an example from the Frailty Project. It brings the data to life. So it is interesting to think about, what do you do if your data set, and it may be the case for your data set, what do we do if there are concerns and patterns in the concerns that don't fit the framework that we've got? Because that may happen. So if it does happen, our advice to you is it is okay if there are 10 instances or more of a new type of concern, that counts as a new emerging concern. Do cross-check with the second coder coding the data set to see if this is something they agree with as well. And tentatively, you can make a new concern to consider which theme it goes within. It may be that you have to expand your practical theme, and there may be specific issues to your high-intensity user group. So you can elaborate on our coding framework. We welcome you to do that, and we provide in the guidance notes a structure for doing that in just the way you record that in a report, because we don't expect you to be able to get all of your data neatly into everything, but there will always be a bit of data that no one can code because it just doesn't make sense, and someone's written something that just does not make sense. So I hope that makes sense in terms of the qualitative data. Has anyone got any reflections or thoughts or worries at this point? No? Okay. I'll do the quantitative data now, if that's all right. So the way this works with the tool, as you realise, is that we have the follow-up scores going forwards. So it's the number change, the fact that we've got that repeated at follow-up, baseline follow-up, and then at the time points that you require. I think you have it at discharge and then subsequently at a follow-up point. Have you agreed that? Is that in place, those timelines? Anyone?
At the moment, Helen,
Yeah.
in Cambridge City, so we're doing it at sort of at the point of discharge.
Just then?
Yeah.
Right. Okay.
at the moment.
Cool. So your quantitative data charts will look like this then. So you'll have your, first time point at the baseline when people came in, that blue bar, which will be the first time point, and then you'll have your follow-up at discharge. And this is the way we suggest you present the data in terms of the mean score across the whole cohort, of the score at time point 1 and the score at time point 2 with the follow-up. And you can add subsequent follow-up time points onto these types of graphs, the mean score. Okay, so the average score sorry. And what it shows you is what you want to show is a decrease in this score, because going down on the scale indicates things getting better. And we've discussed about the time points of when you're collecting the data. We say that please be consistent in collecting the data in those timings, because it helps the data to be correctly collected. We would say, really, you can only start to do more deeper analysis than just this descriptive analysis when you've got pairs of data numbering over 100 pairs. So underneath that, you start to struggle with doing statistics. When you're plotting this data, only plot the data for where you have pairs of data, the baseline and follow-up. Please don't include data where you only have the baseline. So have both baseline and follow-up data here. This contrasts with the qualitative data, where please do take all of the concerns from all that you gather, because if you think about it, you are listening to the needs of your service users. If you haven't managed to follow them up and get the follow-up score, you shouldn't exclude their qualitative data, because their voice is important and you shouldn't ignore them, and it allows you to build up a picture of the needs of people. But in terms of the quantitative data, you do need to have the both before and after to do the averages and the follow-up statistics. So here's where you can start to then plot it in terms of tables. So you can plot the same data as was in that chart in terms of means, and you can have a standard deviation there, and you can start to present statistics if you do t-tests on it. So that white table at the top is a simplified version that you could put in a report. It's got something called a profile score in it. A profile score is good because it allows you to sum across all the concern 1, 2, and the well-being, and that gives you a top-line headline score of the data, and that allows you to sort of, if you wanted to have that at high-level board meetings, you could say that is the overall MYCaW score. And if you've got multiple services and different strands of work, it allows you to just have that data in one small place. Again, please do consider using that Jamovi software for doing this sort of analysis. It's really good for t-tests and things like that. It's a free bit of software. I'll just show you. This is a sort of more detailed table with the mean score at baseline and standard deviation. And then what we're presenting here is the score change, which is the follow-up minus the baseline, which is what's calculated when you do a t-test. And then the t-test would kick out a p-value to say if the data is significantly different and in the right direction for indicating a positive change. That this example of data is from our frailty data set, and we showed that yes, concern 1, 2, well-being, and the profile score were all significantly different in that they all improved. And we also worked out the percentage of people making a meaningful change, and this is a really nice statistic you can get from the quantitative data. This is where there's a 1-point change on the 0 to 6 scale. There's that 1-point change for people over time does indicate people are making a meaningful change to that concern. And if you work out the percentage of people in your sample making that meaningful change, that's really good. So you can sort of have an indicator of the people essentially that you're making a positive difference to. You can also work out the people that are getting worse, because that's the truth. There will be some people that get worse over time, and have that as sort of an honesty check on the data. So that's the far right column there, people getting worse with the deterioration. what services like to do, we find, is have benchmarks of trying to hit maybe 50% of service users, getting them to have a minimal improvement, 50% being the benchmark, and hopefully over time services meeting those needs for at least half of the population. You can choose that benchmark, but we typically find people like 50%. So yeah, that's the sort of the overall with the quantitative analysis. Another way you can present the data if you wish is you could present a graph with the amount of times across the 0 to 6 scale that people make a positive or a negative change to their scores. So you can present it like that if you wish, but we tend not to do that. But what you need to think about here is, so you can get that nice data of the quantitative change. You could benchmark this data against, so one service to another or services over time, and really sort of work out where things are. You could stratify the data for different demographic groups as well. Because I remember we did this sort of work in a cancer population, and we always found that we met the needs of women really well for the cancer support services, but men, they never reached significance in terms of the score changes. And we had hypothesis that maybe the service wasn't reaching the needs of men quite so well, and they designed new services to meet those needs. So that's essentially what the data analysis can do. It can allow you to see globally how's it going for everybody in an overall sense, but you can drill down and split into demographics. You could look at carers, and then you could see if they're different. So I hope that allows you to have a think at this point. Has anyone got any thoughts? What would you like to do with the quantitative data? Any thoughts at this point?
I don't know. It's yeah. I guess we haven't necessarily in City, and Adam and Kate, please jump in, but we haven't necessarily thought that far about what we want to do with the data, apart from demonstrating sort of the individual statistical difference around that. But I think this is definitely given food for thought about how we might use some of it, and particularly because in the HIU cohort that we have in Cambridge City 4, we are working with carers as part of that cohort, so it will be interesting to do some of those comparison data sets, I think, comparative data sets around specific demographics.
I think you should. And if we give the coding framework and then you split the data, you can do the qualitative, paint the picture for carers, and you can do the quantitative, you can produce the same data tables. And it might be that the carers you just are not making a difference to, because maybe their lives, it's a bit, there's more to it.
Yeah.
There's other things going on, which leads me on to the next bit of the training, actually, which allows you to look at other things. But yeah, it's a question of you've got to apply a bit of resource to your end for someone to sit and do this work, I'm afraid. If you want, Meaningful Measures can do this work for you, because we do it all the time. We churn these out for people. But I hope that if someone can watch this training from your end, who has statistical knowledge and able to do this sort of work, it isn't really tricky stuff. It just takes someone to sit at it and do the work, really. So that's the whole point. But you guys need to say, so these are the projects we've got. Which way do we want to split this data? What do we want to know? What do we want to find out? How will this help us going forwards with what we want to do? What will make the case that this is actually making a difference?
And I think, Helen, because we're working differently across different localities, like Rachel had put in the chat that they're capturing their post MYCaW score at a different point. I guess, across sort of from a place perspective, would it make the evidence the measurements or the data collection more robust if we were working consistently across the patch?
Yeah, of course it would, but
Yeah.
I think that this is real world stuff. We're not doing a randomized control trial, okay? It is real world data collection. And when you say there's lack of consistency, do not worry if you've got a couple of weeks difference between, the data collection and it's not exactly on a certain date. Really do not worry about that at all, because this is about real world stuff. So please don't feel it's a research trial. It's not. You're doing real world, evaluation data collection here, which is very different.
Okay, it's just because Rachel's she can't turn her mic on, but
sorry, Rachel.
She's posted in the chat that in EastCams they asked for their post scores to be collected after the changes happened. So that could be 3 days or 3 weeks or 3 months. Whereas in the city we're doing it at the point of discharge. I'm not quite sure for South Cams where they're doing where they're capturing theirs.
Okay.
So I'm just thinking about that. And then Rachel's also put that they've gone through the process for their first 100 plus participants.
Yeah.
And that it was really useful in the report to reflect descriptive and statistical data. But then she's also mentioned that she's keen to use the software package of all of ours with some Excel.
Jamovi is really good. I've just discovered it actually. My colleague introduced me to it. And because we always used to have to pay for the SPSS license, it was a right pain. And you can do the stats in Excel, but it's not as good. Jamovi is brill.
Right, that's really helpful.
Yeah. And it does nice plots of things as well. And you just plug the data in, and it's just a bit of a smooth bit of software. But it's based on R, the statistical package R. But someone's made this free open access version, and it's really good. I don't work for them. I just found it.
No, but top tip. Thank you.
Yeah. And I think the answer about the data collection consistency is state that in your reporting. Okay.
Right, okay.
Don't try and just paper over the cracks. State it. It's okay. It's real world data. Put it all together in one big pot. Fine, but state that the follow-ups were collected at different time points. You can't change that. It's chaotic real world data stuff. It is better to have the data really segmented into the different projects, because then you can get the real power and compare across the projects. And really what you need is to have at least 100 pairs to then be able to do the statistical testing, because it's about power calculation. We typically find if you can get to about 100 pairs, you can be more sure of your results at that point. Please do not do stats tests on 20 pairs, because anyone reading that report that understands about statistics is going to say, this is very, very weak and tenuous data.
Right.
Do not also rely on tiny little pots of data and doing the qualitative work on like 12 people's data. It's not going to give you a representative sort of picture of your population. You need to build up, typically we find, say if you've got 100 pairs, maybe got around 200 concerns, because you can code 2 concerns per person, if that makes sense. But then you will have extra people in that data set that only gave you baseline data. So you probably have about, for 100 pairs, you probably have about 350 concerns to code. That's good. Okay. That's right. And that will give you enough to be able to use and put into that coding framework. It probably takes someone a day's worth of time to code that, and a colleague, to do a 10% check, say, that takes a couple of hours, and then you have to have a little sit down and cross compare. And then you've got to do the Jamovi bit with the frequencies. And Jamovi will also do the t-tests for you as well. Okay.
Okay. Thank you.
So yeah, but I think
I'll just just come in there as well, because I'm aware Rachel. She said she can't use her mic. She hasn't put anything in the chat, but I didn't know if she was kind of preempting some of this, but just kind of give a bit of context as well, Helen. Something we've done, which Rachel kind of originally designed in terms of the data capturing at PCN level, which some of us are adopting, is we have got a centralized Excel spreadsheet where Rachel has taken that framework from you guys and built that coding within to the spreadsheet. So for some of us, we'll be asking the PCNs, whoever's managing that data at local level, once they receive the personalised care and support plan and the MYCaW scores, to actually input that coding into the spreadsheet. So hopefully that will minimise the overall impact when it comes to analysing the data and having to do this whole manual process. Not saying everyone will be doing that, because some teams might have to do that, but hopefully that will just make that collection a little bit easier, and we can do a bit of that spot checking from the theming and the coding that's already happened at PCN level. So we're hopefully building that in as part of the process that people will be responsible for once they're managing these individual personalised care and support plans, and collecting that MYCaW data is on receipt or getting back to the office, or whenever they have that plan of MYCaW scores, they can do that bit of coding, so it's kind of captured straight away.
So do make sure that those colleagues have the access to those coding frameworks.
Yes,
and obviously there's 5 themes, and within each theme there's like a dozen categories and their definitions. The first time you ever do it, it's a bit like, oh, you know, it takes a bit of getting your head round. But you know, I did this so much over the years that I go, oh yeah, that's one of them, that's one of them, and you really get into the swing of it. It does take more time if you just do 5 and put it down, and you know, it's a bit sort of I find that if you get a big chunk of data, it's quicker to do, and it just, you get really into it. But if operationally it works for your colleagues to do their little bits and everyone puts it together, I think it is about doing those spot checks on a big global data set to make sure that there is consistency. There is good guidance on those coding frameworks though, and they do work and people do get on very well with them.
Yeah, and as Rachel's mentioned in the chat, we've got the framework embedded into the spreadsheet, so the guidance is there automatically when people are making their relevant selections for the coding. So, and you know, in an ideal world, all of us will adopt that, so we will get that overall universal picture when we do get to that point where we've got enough data to code all of this as a place-based picture of what things look like. But it could be that initially as we develop and we get more cases and we're doing delivery of high numbers, we'll just kind of do it on a neighborhood basis, and who knows what that will look like in terms of when we do that as place-based to kind of capture the total figures around the data and stratify all of that together. Depends on what our numbers are really, but we're not, as Kelly mentioned earlier, we're not quite there yet in being able to determine what that will look like in terms of numbers. But
I hope that my numbers that, you know, I'm giving you the sort of don't do it under 100 really is the sort of thing for the t-tests, and you know, just really do not, if you then start to segment your data down and you've only got 4 carers, you know, really be careful about that. You can't be doing stuff with that sort of small data set. Just interesting on the Excel spreadsheet and how it's embedded in there. Is that it just embedded as
yes? Yeah, so on the main spreadsheet for capturing the data, it's built as filters within columns for each concern. So there's a column for the theme, then there's a column for the associated condition for each individual concern. But then the framework itself, Rachel has embedded on a separate tab. So they'll just look up the manual framework as like a snapshot reference, if you like. They're not just relying on the drop down selection boxes, they've got it there in full text viewable format on another tab.
So we've worked with another organization in Australia actually, and they've embedded the MYCaW into their own website systems collecting for their staff, and as they collect the data they are able to code it as they go, because they've got all the drop downs as they enter the data, and it's all linked to the coding frameworks. But that took them quite a lot. That took them about a year to work that out, and it's very sophisticated. But that's a charity in Australia. But it sounds like you guys, and well done to you, Rachel. It's the first time I've actually come across an organisation getting that organised. So well done to you, even though you can't speak on this thing. So I hope that's useful for my guidelines in terms of how to do the quant analysis and the qual. The way I've shown you on these slides and the way we've presented the data, that's the way you should present the data, because that's the standard way. So please don't try and invent new ways of presenting the data. You know, those graphs and those tables are the standard way. I hope that's okay. allows sort of consistency of reporting, but do segment your data into different services and demographics. So just moving on, because I'm aware of time, I've just got the last little bit to do, if that's okay. This is about the open questions at the end. So the optional open questions at the end of MYCaW. One about other things affecting your health. We have a coding framework for this one as well, and you may have embedded this into your Excel spreadsheet. It's a mini framework. It's not like the ones for the concerns. We aren't quite as developed with this coding framework, in honesty. We've developed our concerns one more than this. We think maybe your data set may be slightly different to this, our coding. So if you are finding that you have different other things affecting your health categories, I think that the main super categories will be fine, but the categories, then please do engineer this to suit you. There may be things in this data set, which is, other major life events affecting the person in terms of their data, that you could code for in a global sense. What's really interesting about this is you can split them into positive and negative. And our previous work, we correlated all of the data, the quantitative data for score change, with people that said positive things and people that said negative things to this coding framework. And it is just logical, really, that if you've got negative other things going on in your life, that correlates to the MYCaW concern scores getting worse, and then vice versa. Positive things are going on in your life. So this is sort of a reason. So you will have a percentage of people who life is really tough for. They've got serious bereavement issues, work issues, relationship issues that are bigger, wider than their concern, maybe if it was that they just wanted to give up smoking or whatever. This provides that wider understanding, and it really is worth you coding this data and at least presenting the percentage of people in each of the super categories, and then also splitting it into positive and negative. I think that would, you could elucidate and sort of refer to the fact that we've done this correlation work. Maybe you don't need to do that yourselves, but you could just sort of explain your data set in that way. And I think high intensity users may be having very significant other things going on in their lives here.
Helen, Rachel's just popped in the chat that we've got a less detailed framework than the one on the screen now. Okay. So it'd be really useful to have a copy of that, please.
Okay. Sorry that you don't have the detail there. I'll send you the up-to-date thing. It shouldn't be that you don't have that, but I will send that. Sorry about that. Then similarly, we've got the what's been most important to you question. Again, we've got a little mini framework here. I'll send this if there's a problem. Again, I do apologize if you didn't have that. This again is just a very nice thing. It allows you to monitor what people are saying in terms of their experience of the support received. We generally find that people write positive things here and say that they're appreciative with people's support, the connections received, information, and just generally appreciating things. It's quite easy to code this data. The quotes you get are useful and nice to feed back to staff teams, as long as they're anonymized, of course. I feel like my voice has been heard, and having someone listening to my concerns, and we always used to feed this data back to the charity I worked in, to the staff teams, and it was just really nice to do. You will get some things that people say, oh, I didn't like this or whatever. Again, that's useful learning. So those open questions at the end are quite straightforward to do. So that is the sort of how to use the data slides, and I'll just come back to the thingy. I hope you all still retained consciousness mostly throughout that. I hope you're all right. Yeah, I'll just check anything else in the chat. Please do ask me questions now if you feel I haven't answered the things you wanted to know about, or if you're happy. Yeah, Have you had enough?
It could be that we'll be knocking on your door near the time, Helen, just to go through things again. But really helpful to have this recording available so we can all refer back to it as we need to.
Please do.
Yeah.
I'll maybe stop recording, and